It's an absolute pleasure of mine to introduce Associate Professor Susan Mathers, who I've worked with for the last 32 years of my professional life. She's the director of Calvary and has established and studied multidisciplinary clinic function in the state of Victoria, leading to the deployment of two satellite clinics covering the entire state, serviced by the hub of Calvary Healthcare. And it's a pleasure to hear what she's going to tell us about Monepantel. Thank you, Susan.
Thank you, Paul. It's very nice to have you here. And thank you to the organisers for inviting me to present our phase 1 study on Monepantel. On behalf of all the participants, the study team and Pharmost, our Australian local veterinary pharmaceutical company who are here today. I have no disclosures. So Monepantel is a drug being repurposed from the veterinary world. It has been approved in many countries around the world since 2009 as an anthelminthic in sheep. So it's used as a sheep drench to kill roundworms. The nicotinic acetylcholine receptors that Monepantel works on to kill these worms do not appear in humans or, in fact, in the worms that infect humans. So we're not going to be having any beneficial effects on the side if you're carrying roundworms and have MND. It's interest of using it both in human cancers and also in motor neuron disease and other neurodegenerative diseases arises from its recognized role as an mTOR inhibitor. mTOR stands for mammalian target of rapamycin, and as you would know, rapamycin itself is being studied as an mTOR inhibitor in MND. So, moving right along, mTOR inhibition and the mTOR pathway are very important for homeostatic mechanisms in immunity, in metabolism, and most importantly, in what we're going to talk about today, in protein homeostasis within cells. And so what we are hoping to do by giving people with MND an mTOR inhibitor is to enhance autophagy and to promote the removal of accumulated toxic, misfolded, and unwanted proteins and organelles from cells. And we've been learning a lot about that these last 2 days. So we're not trying to push autophagy all the way to cell death, as you might try to do in cancer. We're trying to equilibrate and restore the homeostatic mechanisms and promote cell health. So the study design was fairly typical. Phase 1 study, it's aimed at proving that this drug is safe and tolerable to give to humans. And to try and pick a dose that would be suitable to take forward to a larger phase 2 or phase 3 study. Along the way, of course, we're interested in collecting some preliminary efficacy measures because we all want to know if our drug's working. We recruited 12 people in all. 11 of them turned out to be men. 2 other women failed screening. And the 2 sites were my own site here at Calvary in Melbourne and Professor Dom Rowe's site at Macquarie University in Sydney. We measured the usual things, ALS, FRSR, respiratory function, some cognitive screening with ECAS, some quality of life measures that we all do in these sorts of studies. And we caught the NFL bug and measured NFL in serum and in CSF in 3 patients who volunteered to have lumbar punctures across the study. So the average age of our patients was 63, and the most common site of onset was upper limb. The diagnosis was probable or definite in all of our patients. and the median duration of disease from onset to the time they entered the study was 14 months, so relatively early. Their baseline estimated slope of the ALS-FRSR pre-dosing was 0.74, so relatively slower than average. And their ALS-FRSR at onset at median was 39.5, so a mildly disabled group of people. The study design, financial reasons in particular, we recruited 6 people into the first cohort, and they were given 2 milligrams per kilogram body weight of Monepantel as a single oral dose each day for 30 days. And the safety data was reviewed by the safety committee before we were then allowed to recruit the second cohort of 6 people who received 4 milligrams per kilogram. And then as safety was ensured, we allowed cohort 1 to move to the 3rd level of dosing at 6 milligrams, and then subsequently cohort 2 moved to the 4th level of dosing that we planned, which was 10 milligrams. This has been a very safe and well-tolerated treatment, probably the most easy trial I've ever done in my career. We had only 3 mild adverse events that were thought possibly related to Monepantel. One was a raised liver function test that was relatively mild. It happened on one occasion and resolved with no intervention at all. One person developed constipation that the investigator thought might be related, but as you know, it's a very common symptom in MND. A couple of people noted that the hairs on their arms and legs grew better, but we didn't cure any baldness, unfortunately. We had one serious adverse event. One of my patients was hospitalized with pneumonia and some abdominal bloating that again resolved with appropriate therapy, and I didn't consider to be related to the drug. We looked at ALS-FRSR slopes, and as you can see, there is no statistical differences here, but the people on the higher doses appear to have a slightly lower slope, although they had in fact had a higher slope than the cohort 1 pre-dose. And as I said, we did measure NFL levels, and those were all analysed in local Australian labs, research labs. And the interesting thing, I suppose, is that NFL levels in all 3 participants who had lumbar punctures did fall across the study, and the 2 who were taking the higher doses seemed to fall more than the lower dose. If we looked at the serum levels of NFL, of which we obviously had more, we didn't see as dramatic an effect, more of a stabilization, particularly in cohort 2 at the higher dose. Measured P75, Marie-Louise Rogers, who talked yesterday, and what we can probably say is that in the higher dose, people's urinary P75 seemed to stabilize rather than the expected gradual increase in level across the disease. I won't go into detail in the pharmacokinetics. There seems we didn't have a completely proportional increase as you increase the dose, and there may be some ceiling on the metabolism of Monepantel into its active metabolite, Monepantel sulfone. But we were able to measure both Monepantel and Monepantel sulfone in the CSF at all the dose levels. And we were able to show target engagement in peripheral blood mononuclear cells, looking at ribosomal protein phosphorylation, which has been used as a marker of target engagement of the mTOR pathway. Berry Consulting in the US have had a look at the data, and they have matched the 12 participants in our study with controls from the PROACT data and shown our patients that appear to have had a more favourable course in terms of their functional scale and their survival, although it's not reaching significant levels. So in summary, this has been a very safe, well-tolerated treatment. It's shown some positive signals in the biomarker readings, although obviously it's a very small number of people. It does cross the blood-brain barrier, both in its basic state and as its active metabolite. It has had some favourable comparisons with the PROACT database in historical controls. And the larger dose of 10 milligrams per kilogram has been chosen as the dose going forward into a pivotal phase 2/3 study. And just recently, Monepantel has been accepted onto the Healy platform as one of their trials in the near future, which is great for Monepantel and hopefully for getting results of a larger study as soon as possible. Sad to say at the moment that won't be happening in Australia. I'd like to thank particularly our participants. They've been a great bunch of people to work with, and they're continuing on in an open label expansion study, and some of them are still contributing CSF or biomarkers. I'd like to thank FightMND, who partly funded this study, and my team at Calvary and the Macquarie team under Professor Dom Rowe, the 3 universities who helped us with the biomarker and PD analysis, University of Tasmania, Flinders and the Florey, and Alithia Life Sciences were the CRO for the study. So thank you.
We've got time for a couple of quick questions before we move on to the next.
Thank you very much. Wonderful talk and data. I was wondering what is your take of the P75 stabilization, considering the mTOR pathway role in the immune response? Would you consider this more a target engagement or rather something related to a pharmacodynamic effect or treatment response?
I take it urinary P75 is a measure of neuronal breakdown, and so I'm assuming that we're seeing less neuronal breakdown, less neurodegeneration as a result of the treatment. In terms of it's stabilizing, it's not gone down like it has been shown to go down in some other studies.
So that the extracellular domain P75 is actually also implicated in the inflammatory response. So, I mean, it's probably both way of looking at it. It looks very encouraging.
Yes, I mean, obviously in the rapamycin studies, they've been looking more at inflammatory markers of effect. We haven't done that as yet in Monepantel, but both could be happening at once, as you say.
Yeah, in the rapamycin clinical trial, neurofilaments didn't change a great deal, whereas here there is a good response. Thank you.
One
He's down.
further question.
Thanks for the great talk. For the Healy platform trial, as a pivotal phase 2/3, I was just talking to Gethin and he was saying he thought it might be longer than the 6 months. Is that true, or will it be another on the standard protocol of 6 months, placebo controlled?
I would need to throw that one to Pharmos, who are in the audience.
Okay. I can ask them after.
John, do you want to answer that, John Clark?
Michael, do you want to talk to that?
The new protocols.
Yeah.
Okay, all right. Are there any other? Leonard.
Yeah,
Use my microphone.
it's going to be recorded, is it? Okay, then I change my question to So how was the comparison with the PROID database? How was that being done? Is that like, because you have a kind of an unbalanced, there are 10 men, one female. Is that same from the PROID database? I mean, how was it done, the analysis with the PROID database, the comparison? Was it like a one-to-one comparison with the patients, the patient characteristics in your town? They're matched, yeah, that's what I mean. Yeah.
360 out of the
Yeah.
database. Yeah, that meet, you know.
And that was still not significant, the change, because it looks very significant, but it's probably done by a pharmacist, was it? I don't have that data. That yeah, they found it to be a very interesting finding. Yeah. Yeah, it is an interesting finding. Yeah, I don't want to change that. Thank you. Thank you.
All right. And on that note, I think we will finish the session there. And if you'd like to join me in thanking all of the speakers that we've had for those invited presentations.